Hello, everybody, and welcome. It's Men's Health Week, and it's a very sunny day, which is very nice. And we're here to launch P for Prostate, which is the manual that the Men's Health Forum have decided to produce for this year's Men's Health Week. We produce one every year. And this year, well, we took our lead from the very highest, and I'll come on to that to talk about that in a moment. So, who are the Men's Health Forum? I'm sure you already all know us. We've been long-term friends of RVS, and we here most years. The Men's Health Forum is the leading charity supporting men's health in England, Wales, and Scotland. And our aim is that all men and boys have the information, services, and treatments they need to live healthier, longer, and more fulfilling lives. Because here, even in the fifth or sixth richest country in the world, many men are still dying way too young. My name's Jim Pollard. I started writing about men's health many years ago when I had cancer in my early 30s. Which is not something you expect at that age, and I wrote a book about it. I've kind of been writing about and talking about men's health ever since, and you can see my most recent book about men's health on the screen there. And for the Men's Health Forum, I edit their websites, but I also wrote P for Prostate, and I tend to write most of their manuals for them. So I said we're all about helping men live longer, more fulfilling lives, and you can see the scale of the problem that we still have in this country. 1 in 5 of us males will die before we're even old enough to retire. So 1 man in 5 dies before he reaches the age of 65. I'm sure everybody out there knows a man who's died before he's even been old enough to retire, because we're talking about 1 person in every 5-a-side football team. If we also bear in mind that there's many men living well into their 90s, it goes to show the enormous potential that we've got in terms of improving men's health. There's no fundamental difference between men who are living to their 90s and the men who are dying in their 60s. So if we can provide the same level of service to everybody, we can massively improve men's lives and men's life expectancy. So today we're going to talk a little bit about the prostate. And don't worry if you're sitting there wondering, what is the prostate? What the hell is this guy going on about? Because in fact, 44% of men don't know where it is, and 74% of men don't know what it does. So we're going to deal with those 2 questions very, very shortly. And this is not fake figures I made up. This is research from our partners at Prostate Cancer UK, who helped us put in this booklet together. And the reason we're talking about prostates is all down to this man. I can't remember his name right now, but he's very, very important. No, when the King spoke about his prostate problem earlier in the year, the number of visits to the NHS webpage about prostates increased 16-fold in just 24 hours. So this page, which gets on average of about 1,000 hits a day on the NHS website, went up to over 16,000 just because King Charles had happened to mention this issue. So this shows how many men needed to find out about their prostate, how many people maybe were surprised to hear him start talking about it. But it also shows to me the enormous potential of sharing our stories. Now, obviously, most of us are not going to have the same impact as the King talking about his prostate. But later on, we'll be talking to Nick, who'll be sharing his story about his experience with prostate cancer, and hopefully that will, have an impact on some of the people, some of you guys out there listening, and it just shows the enormous potential that there is when we start sharing stories and start talking about stuff which traditionally we men have been very reluctant to do. So if you are one of that 44% who don't know where the prostate is, there it is on this very, very handy diagram that our cartoonist drew. You can see it kind of sits there just below your bladder, encircling the urethra. So you can kind of possibly imagine what might start happening if the prostate gets bigger, the impact it might have on your urethra and on the bladder. So, a couple of questions. There's a few people out there in comments. Let's see what we've got here. Hello, everybody. If you want to answer these in the comments, feel free. So the first question that we have is, what is the job of the prostate? To filter water before it enters the bladder, to protect the urethra, to produce enzymes to protect sperm from bacteria, or to help the liver process alcohol? Nick, I know you're a nurse, so I'm pretty sure you know the answer to this.
Actually, that's an interesting set of questions, and I must confess, perhaps I've been retired too long, Jim, but you put me on this.
No, you don't. Don't worry.
It's probably C, isn't it? I don't know.
We haven't had any suggestions from the chat. There's people just saying hello to each other at the moment.
Yeah,
so,
yeah.
Yes, well done. The answer is C, to produce enzymes.
Oh, well, that is a relief.
Congratulations, Nick. You still deserve your nursing diploma. So yeah, that's what it does. That's why it's very, very useful. The journey of the average sperm to fertilize an egg is through a number of hostile environments, and the enzymes provided by the prostate help it make that journey more safely. So it's a very, very important part of the human species reproductive health. The prostate. We don't need a prostate to live, but if we do need a prostate to reproduce. Which of these cancers is more common in UK men than prostate cancer? Lung, bowel, testicular, or liver? Again, I'm looking to the comments, hoping someone's going to make a suggestion in there, in our audience in the virtual village hall. But can't see any. Nick, do you want to have a bash at this one?
Oh, come on.
Yeah, I didn't want to put you on the spot. Okay, thank you very much, Catherine. Catherine says possibly bowel is more common in the UK than the UK.
Yeah, that's good for Catherine.
Thank you very much. Anybody else out there want to hazard a guess? Okay, well, Catherine, yeah, it's a trick question, I'm afraid. The answer is none of them. Is that what you were just saying, Nick?
Oh, no, I was burbling. Don't ignore me.
So, yeah, the answer is none of them. So prostate cancer is the most common cancer in UK men. It's not the most common killer, and I think Catherine was right about that. Bowel cancer does kill more men than prostate cancer, but prostate cancer is the most common cancer in men. And this one's a bit more difficult. At what age should men be discussing their prostate cancer risk with their GP? And in a way, if you don't take anything else away from our conversation today, this is probably the most important thing to share with the men in your lives, or obviously the men who are out there listening. This is probably the most important thing that you need to take away with you. At what age should you be discussing your prostate cancer risk with your GP if you haven't already done so, obviously? And we get a lot of people suggesting 40, and you certainly should be doing that if you've got a family history of prostate cancer, especially if you've had father or brothers who have had prostate cancer, but also if you've got amongst the women in your family history of breast cancer as well. So it's not just prostate cancer; it's some of the female cancers as well. 45 is the age for when black men really need to be talking about prostate cancer with their GP, and 50 for white men. And why is that discrepancy? Well, you are twice as likely to get prostate cancer if you're a black man than if you're white. Prostate cancer affects 1 in 4 black men compared to 1 in 8 white men. So it's particularly important for black men to make sure that they're aware of their prostate cancer risk. So thanks very much, those of you who participated in the quiz there. So there's a P on the bottom left of your screen there. That's the size of the prostate when we're born. So that's a little boy's prostate. It's the size of a P. At puberty, it grows considerably, and so the average size of the average prostate is about the size of a walnut. But then prostates do grow in most men. It's a fairly natural process to do with the way that the body processes testosterone. So growth of the prostate is not of itself unusual. The problem is the damage that might have on you, and obviously that it can be cancerous sometimes, the growth. So growth up to the size of an apple is not unusual. And you can imagine the difference in size between the walnut and the apple in the area where the prostate sits can have considerable impact by pushing on your bladder or on the urethra, and obviously can make urination much more difficult. These are the sorts of peeing problems that you can get. We're talking about a weak flow, a flow which stops and starts, having to wait before you start to go, so you're kind of standing there waiting to go to the toilet forever. Having to urinate more often than previously, so you're not kind of really finishing properly, and you have to keep going to the toilet over and over again. Urgency, finding it difficult to postpone urination, so sort of suddenly needing to go, and nocturia, which is basically having to get up a lot at night to pee. And in a way, that's often the one that men notice most because it has a knock-on effect, obviously, on your fatigue levels and quality of sleep and so on. As it says at the bottom there, prostates grow as men age, so it's probably not cancer, but you do need to know. So it's important to talk to your GP if you're having any of these symptoms, so that cancer can be ruled out, but also so that these symptoms can be treated, and they all can be treated. Other symptoms that may be prostate related include a stinging, burning pain when urinating, which could be a sign of prostatitis, blood in the urine or semen, bone pain, especially in the back, hips or pelvis, erection problems, or unexpected weight loss. All of these things can be linked to prostate problems, particularly in the last few there on that list, prostate cancer. There are sort of 3 main conditions, and these are all described in detail in the booklet, as all those symptoms and everything I talked about, they're all described in more detail in the booklet. So there's 3 main conditions that affect the prostate. There's benign prostate enlargement, or BPE, or sometimes BPH, people call it. That's non-cancerous enlargement of the prostate, which is, as I say, fairly normal. Most men will have that to some degree. It's just a question of how much impact it has on their urinary function and so on. There's inflammation of the prostate gland, prostatitis, and that can be acute in the form of an infection, but it can also be chronic. Some people can have prostatitis, chronic prostatitis for long periods of time, and it can cause a lot of pain. Again, definitely worth getting some treatment for. And lastly, prostate cancer is the kind of 3rd main condition that affects the prostate. As I said, one white man in 8, 1 black man in 4 will get prostate cancer. And we are seeing it in younger and younger ages. Whilst most diagnoses are in men in their 70s, we are increasingly seeing diagnoses in men in their 50s and 40s. We'll be talking to a man who's well short of 70 in a minute, who's had prostate cancer. So just to leave you with this, really, all of those conditions that I've mentioned can be treated, but they're only going to be treated if you see a doctor. And obviously, one of the things we know about men's health is we can be very reluctant to go and see doctors, especially for something that we think is going to be difficult. We don't really want to get bad news about things to do with our waterworks. We're also worried that it might have an impact on our sex lives. But all of these things can be dealt with. All of these things can be handled. But you do need to see a doctor in order to get a diagnosis. Earlier intervention is always going to be best. There's a massive difference between treating particularly prostate cancer when it's caught early and when it's caught late. There's a whole load of tests, including blood tests, urodynamics, ultrasound, scans. We're going to be talking about all of those things with Nick in a moment. And there's a whole range of treatments, including active monitoring, where you just the doctor will just keep an eye on the prostate, see what it's doing. Drugs, particularly with benign prostate growth. Surgery, obviously, which is becoming increasingly non-invasive, using robots and keyhole surgery, lasers and so on. And obviously, if it's cancer, there's also the possibility of radiotherapy and chemotherapy. So there are a whole load of things that can be done for prostate problems. The interventions are getting less and less unpleasant. So whilst, once upon a time, you might have thought, the only thing that they can do is take your prostate out, and it's going to be very, very damaging and invasive. Now they can take your prostate out in a way which isn't as invasive, but also there are a whole range of treatments short of that which can deal with the problem for you. So I'll just leave you with this on prostate cancer. It is the most common cancer in UK males. It is increasing. It's expected that rates will be up by 15% by 2040. Again, that's Prostate Cancer UK research. It affects 1 in 8 white men, 1 in 4 black men. Despite everything I've said about the symptoms, it is also possible for prostate cancer to be symptomless. So it is really important to talk to your GP about your own personal cancer risk, because then he can decide, or she can decide, whether it's a good idea to have a blood test. So all of this stuff is in the P for Prostate manual. It's really easy to read, full of cartoons, and it explains how the prostate works, what can go wrong with it, the signs and symptoms of a problem, the tests and examinations that can put it right. We also talk about the treatments in a bit of detail so that you can see what the options are. And we look at all aspects of prostate health, including life after your diagnosis. For the duration of Men's Health Week, the booklet is available, I think, at £3.95, and then at the end of Men's Health Week, it goes up to the normal price of £4.95, and you can also buy them in bulk. Somebody tell Kevin I said let's talk prostates, not let's talk prostrate. So there's an example of the cartoons, and also an example of a common error amongst men, that we often think that we've got a prostrate, not a prostate. I'm now going to talk to my friend Nick, who's had his own experience of prostate cancer. What I need to do is figure out how to take the slides down. How do I do that? Oh, well, we've done that. Thank you. Fantastic. Hi, Nick.
Hi, Jim.
Well, perhaps you just kick us off by saying, how you first became aware that there might be an issue with your prostate.
Okay, yeah. Thanks very much, Jim, and thanks for the invite to share some of this stuff. And I think that these stories are really helpful. I certainly began to read on the web and various other materials about people's stories, and I'll be talking about my own experience. And I think that Jim's booklet here has a number of case studies there with different kind of stories and different experiences, and I think it's important to kind of it makes me think about it, because everybody's story is different. And early on in my pathway, I remember reading some that I I didn't finish. And even now I kind of read that, you know, other people, and they have different pathways and different outcomes, and I'm a bit wary of them. But so do read widely. You know, there are 2 others in this one, aren't there, Jim?
There's 5 altogether. 5 altogether.
Five in there. So it's really worth gathering, if you know, if you wanted to read broadly to further than mine. But as Jim indicated, I worked in the NHS for a long time as a nurse. Married, 2 kids in their 20s now. I'm 66 now, and my story started about 3 years ago, really, when I began to get worried. But it was a long journey, and Jim has helpfully pointed out a range of symptoms that made me think, and I've less excuse really not to have acted earlier, really. I worked as a nurse in a whole range of different settings, but very early in my career I did work with a chap who came into the emergency department with acute retention, and that was a very obviously much more uncomfortable experience for this gentleman, but as to witness it was kind of very important in my kind of thinking. And so I had all the kind of information that this happens to men, and that there are things you can do and you should take action. But for the reasons Jim kind of already sketched out, I didn't. I mean, I did I did hassle my GP around 40, I think, Jim, something like that, to, you know, do my PSA. I'm worried about it. And for a number of years, I tracked my PSA because I persuaded them, because at that time, I don't know what their policy is now for younger men in doing a PSA, because again, in Jim's booklet,
just to say, everybody, sorry, Nick, I didn't explain very well what a PSA was, did I? So PSA is the prostate specific antigen, which is what they're looking for when they do a blood test. The blood test that I mentioned, and an elevated PSA can be an indication of cancer, although not necessarily, and that's one of the problems with the PSA. Anyway, back to you, Nick. Sorry, I should have explained that earlier.
No, it's useful to have that, and mine ran in the normal range, but then I think it was around, something prompted me, and I wish I could be more helpful in saying, you know, I should have it again. So I think I may have been having it every 5 years, something like that, and then it did just be mildly elevated, but it did kind of bring into focus that I did have urinary symptoms as described in the booklet. I was going to the loo more at night, and I found it, I didn't mention this when I first spoke to you, Jim, but I used to, I think at least once, they use kind of fruit, the nut analogy, and I used to go to the loo, and I think my friends used to say, "Oh, you going to the loo a lot?" And I said, "Yes, my prostate must be like the size of a melon," I used to say. I really felt like, and the other image, because when I was younger, my parents used to love Dad's Army, and there was Private Godfrey, and these kind of iconic figures in sitcoms, sort of. And you don't want to be like Private Godfrey, and my brain was saying, this is.
You're in denial about it to some extent. You just.
It is like, this is happening to you, Nick. You are becoming like this. I've got to go. Excuse me, Captain Mannering. Can I be excused? And there was there was a lot of resistance. I had no real excuse as to why I didn't act and get that PSA done. I mean, perhaps it was I was really nervous that it would, because of these symptoms, be up, and lo and behold, it did go up, and that was the beginning of my journey, Jim. And I mean, should I just talk through the main bits?
Carry on. So what did you do? You're having the symptoms for a while. You're private
denial.
You're pretending you're not.
Yeah.
You've had a PSA test, and it's slightly elevated. Is that point where you kind of thinking, I need to do something about it, or you still kind of?
I did, and the GP was very, brusque. He said, "Okay, you're going to have a referral to the urology department in my local hospital. And so, I knew about benign growth, and I thought, well, let's just hope it's that. I had worked on urology wards, and of course now it's quite frightening how old one is, but a long time ago, and they were always a challenge, I think, for a male nurse really to work in those areas when they were seeing the kind of surgery that was going on there. It was quite as I said earlier on with the A&E experience, it's kind of like a real challenge for a man to kind of deal with that. So next stage was a consultant specialist urology, and had the digital rectal examination. And the outcome, I remember coming out of that meeting, he said, "Oh, you got a mildly enlarged, benign prostate." And I thought, okay, that's fine. And I was very much reassured. But then he did another, he called it like it's described in the leaflet again, a free PSA test. So I went away thinking and reassured that this was, because I was still quite anxious, because I'd seen the surgery that generally was used, to address and shape. I'd seen, these operations taking place, and I thought, okay, well, hopefully they've got better since then, even if it was benign.
You were haunted by the sort of images of sort of 1990s prostate surgery.
Yeah. It was, and Private Godfrey, and the kind of life.
You mentioned there the DRE, digital rectal examination, which is basically nothing more or less than the doctor sticking his finger up your bottom.
Yeah, that's right.
And a lot of men are really intimidated by that, aren't they? They're really, oh God, I don't want to go and have that done.
Yeah.
But I mean, it's no big deal, really, is it?
No, it isn't. I remember the time, and it's not. And being a nurse, Jim, I've been involved in procedures that involve that. So I mean,
have you done them the other way around?
Yeah,
you administered some. Yeah.
But now I'm a keen cyclist, so I then went. I climbed a few big mountains in Italy, and I came back and with a message from my wife saying, "Oh yes, the urology people. Can you contact them? And apparently you're on the cancer pathway." And so it was a bit of a shock. And actually she knew, but she'd left me kind of pedaling up and down Italian hills until I kind of came home. And I remember ringing them up and saying, "I think there must be some mistake here, because nobody's told me that I'm on the cancer pathway." But then, as she kindly explained, I was. And so the next stage,
that was to do, I think, wasn't it, something to do with the difference between your regular prostate and the regular PSA test and the free PSA test? Can you explain
that's
that?
Right, yeah. I remember when the result of the free PSA test came through, it just looked, I mean, I still can't remember the details of the number now, but I don't know quite how it works, but there is a matrix that I found that, this level in my age group was indicative of a malignancy rather than a benign one. And I think that's what must have triggered them putting me onto this pathway. And the next stages in that pathway were urodynamics and MRI. And I don't know whether anybody listening to this has been through urodynamics, but it means going to a clinic. You arrive and they tell you to drink loads so that you've got lots of pee in your bladder, and you pee into various funnels, and various equipment measures how voluminous your pee is, about your flow. They also do an ultrasound of your bladder to see how much urine is left in your bladder after you think you've finished having your pee. And I think they were quite surprised about how much I had left in my bladder after I thought I'd finished. And I think it also explains why I'd go to the pub, have a few pints, go to the loo, think I'd had a pee, come back, but I still had a load of pee stuck in my bladder still, and it was the prostate, whatever's happening in there was blocking its normal exit out of my body.
So how are you feeling as you go along this pathway? Each kind of bit, there's a kind of another thing that happens, so we've got the pre-PSA and the regular PSA are suggesting something which are a bit worried about. Then the urodynamics,
and that's right, and then the MRI, and I think in this kind of health thing, it's a kind of a dawning awareness. There's this fear that sits in the background, but you kind of seek reassurance in bits of information that say, oh no, it's probably all right, and you kind of grasp for them as you go through. So there was a dawning awareness, and then as a few of the other case studies talk about the physical biopsy where they actually I had it under GA, but there's a case study in the booklet where he had it under a local anesthetic, and this involves sort of shooting a number of needles through your perineum into your prostate gland, and then they analyze samples from each of those needles. I can't remember how many there are, but there are a significant number of them, so it was quite uncomfortable, but mine was under GA and I didn't find it too distressing.
General anesthetic.
Yeah, I had it under general anesthetic. Yeah, other people have had it under local, and then there was this fateful COVID appointment where it was all locked down.
Can you just back up, because you haven't really mentioned the MRI scan, which
the MRI. The MRI came back, and again, nothing to that point was definitive. They said, "Oh yes, there's a shadow. We can't quite see what it is."
Just describe what they do in the MRI for people who haven't had it.
Yeah, I mean, again, that is an experience and a half, really, in that you have to have contrast injected into your system, which means you have an injection into your arm, and they pump this stuff in that enables them to visualize the prostate in the X-ray more clearly. And so you sit there, you turn up, they inject the stuff, you sign your consent, and then you sit in a machine for an extended period of time. I think it's like 40 minutes, and then they take a series of pictures that make the machine kind of. Have you had? I'm sure you've had them, Jim. They kind of they thump, and they have a kind of a visceral. It goes boom, boom, and you kind of thinking, oh, this is not so bad, and they play your music, and oh, da 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 da. But then after about half an hour, it does begin to get quite oppressive and sort of unpleasant. I mean, not terribly unpleasant, but you just want it to be over.
Yeah.
And the end, again, you wait for the results, not definitive, but not that by they say, oh, Mr. Hale, it's clear, there's nothing there. Oh, Mr. Hale, we don't know what's there. It's a shadow. You need to have a physical biopsy, and you're right, Jim. That's what I was talking about the next stage in the diagnostic that was in the end.
Being told there's a shadow. I mean, that's a
shadow. That's all I was told, and they didn't. And I remember when I was waiting for it, the people who prep you up, waiting for the actual biopsy, which was the next stage, the stage after the MRI. And she was being very kind of reassuring. Oh no, don't worry. It may not be. It probably isn't. It probably isn't malignant. It probably isn't cancerous. And I remember I said, go and have a look at my notes. Look at the MRA. Look at the PSA. Look at my urodynamics. I think probably it is. And then I remember her coming back into the room, thinking, oh yeah, oh okay, yeah. Well, let's. You still might be, and I think these things combine, that you grasp at straws that it might be all right. So I think even when I had the shadow and you go on to the next stage, you still think there may be a little let out, there may be a back door out of this, that it's all okay. But to go back on, it was a dark, rainy afternoon, typically. Whether it was dark or rainy, I don't know. But in my memory, certainly it was a dark and rainy and empty outpatients department, because we were all separated out and it was very few
people. In the middle of COVID.
This is in the middle of COVID. And so I was on my own, and you kind of sit outside the office and, waiting for your call. And again, you're just thinking, oh, it probably is. And, but, hopefully it isn't, hopefully there's some other, but you went in there, and I went in, I remember thinking there was another male consultant, and there was another nurse, and she was introduced as the Macmillan nurse. And I think then the things were falling in, the way out of this, the way out of this in a happy ending were kind of rapidly kind of diminishing. And then he gave me the readout. I told you about the number of needles. He said that we found in X percentage of the needles of the biopsy this cancerous cells, and they were very good. There was no kind of I would kind of say, oh, well, that's okay, what do I do next, kind of thing. And they said, well, you're lucky, he said, that today we have the radiography people in this office this room down the road, down the corridor, and the surgeon a bit further on. And and so we've, that it's fine for you now, rather than waiting to see the relative consultants who would be leading different treatment options. I think he did do the watchful waiting option as well, but I was of a kind of pessimistic inclination, so I thought, let's get. I remember saying, well, what am I waiting for? Am I just waiting for am I just waiting for that to happen? So I think I eliminated that from my inquiries quite early on. Anyway, so I saw a lovely female radiographer who had a colleague with her, very supportive, very clear in talking through what the options are, what that radiotherapy treatment would be like. And again, they're all described in detail. I can't recall from my memory what she said, but it's all in the leaflet. And I ummed and ahed, and I thought, okay, yeah, that sounds interesting. And then I went in to see the male surgeon. And I've worked with a number of surgeons over my career, and he was very kind of direct and assertive, and said, I'm very good at this, and I've got this great machine. And I was drawn by the techiness of it. He seemed very clear, and it was all hands off, because we were kind of 2 meters, 3 meters separate from each other. And he talked about robots and lasers, and I think I was quite impressed. And he said something that stuck in my mind. He said that you can have radiotherapy. It has very similar outcomes to this, but if you ever needed surgery again, because radiotherapy can affect tissues around the actual tumor, it's probably better now. And he said, well, if you did need surgery down there again, maybe it would have an impact. And he was very good, and all hands off. And mostly surgeons do palpate. And so I said, thanks very much. And again, the Macmillan nurse was kind of a companion through this journey down the corridor with these different people. And I remember feeling quite robust emotionally with the practicalities of, particularly when I began to think of robots and things like that. And but then they asked about, do you want anybody to be in here with you? And should anybody be here with you as you deal with that? And I think it was then I kind of, the practicality of it kind of broke down into the kind of the emotional response. And I can remember feeling really kind of emotional and upset as I contemplated having to talk to, my children in particular and my wife, to kind of talk through everything that's been going into my head. And I think that's where the Macmillan nurse was kind of very helpful, very personable, and kind of, she was the one that went through that, the initial, it's bad news, Nick, go and see the radiographer, go and see that. And she was able to kind of put a few things in perspective about what my choice was. She gave me the option of, do you want your wife to come in now? And, she was very important kind of role in dealing with the kind of, because otherwise I was the only one who was holding this information,
we'll come on to the emotional stuff, and I just want to say a couple of things arising from what you talking through your treatment, because it's really interesting listening to you that how much things have massively improved from when you were working on the wards when you first started nursing, and what happened to you. But in fact, things are massively improved even in the since then. So you were talking about radiotherapy, and maybe that's improved, and it has. In fact, there's a case study of one of the other guys in the booklet who had this kind of very targeted radiotherapy that they can do, which has only recently come out of trial, and so that's an area of improvement which is happening right now. And the other one is there's some research going on in the UK right now into MRI without dye. So using artificial intelligence to analyze the thing, they don't really need the dye. So that reduces the time it takes, reduces the cost, and all of those things could improve the rapidity of MRI diagnosis in the future. So the reason I'm interrupting Nick to say this is to really make the point to people who are listening that this stuff is getting better all the time, and all the fears that we have about how the treatments might be are often, as even in the case of as Nick's just said, someone who works in the industry, based on 10, 15 years earlier, and things are getting better all the time. So Nick, just to come back then to this sort of emotional reaction, and I know that your wife and your daughter were really important in your journey, really.
They were. I think they both were the prompts to ring somebody up. Again, backing back a bit, it's the fact very early on the prompts to go to that GP and to address the PSA and just get the whole thing in. I remember it was just sitting at home watching a movie, and I've gone to the loo once, gone to the loo twice. And my daughter said, "You've just got to do something." And in light of what Jim has just said in terms of improvement, and I kind of this kind of conflict I have in my head is I should have known, but I suppose in the context of what Jim's just said, what I knew was like what surgery was 30 years ago. That formed why I didn't perhaps do anything, whereas I had all the kind of cognitive stuff, but the fear of seeing some of the treatments prior to that. I'm not saying they were all disastrous, but in the kind of my kind of work, I did see some very men going through very challenging experiences, and I think that was the kind of the conflict in my head. I knew but didn't want to know, and as I said, it was bringing together. I just could not deny it. And my daughter, my wife, that they said, this is, you've got to do something. But then, so coming out of that, all the information that the surgeons and the medics had at that were brought together with those options, and they sent me out of that committee. It was the Macmillan woman nurse who said, well, just take a few days now and chat it through and give us a ring and tell us which way you're going to go. And of course, then talking to Alison, my wife, was critical in that. And also, she's the one that I think forced me to tell people. I mean, I was, again, I don't know, just wanting to keep it to I can deal with this. I can sort this out. But then she said, you've got to start talking to your family. You've got to start talking to work, because I was working, and all this sorting everything out like that. quite critical in kind of, but just not just saying, oh, it's this treatment or that treatment. It was like the rest of my life, you have to readjust, you know, and to accommodate this challenge. And again, and then just I don't know how we're doing for time.
Coming up 10-2.
10-2, and so I decided at that point, well, after a couple of days, talking to my wife, talking to people, that I'd go for surgery. I was persuaded by the man and his robot. I said, this is the way forward. And he was very good. He had very open. I could ring him up directly at that time and say, listen, I want to go for that. And he kind of looked at his calendar and said, well, we can fit you in I can remember him saying, we can fit you in November, which gave me about sort of 4 weeks, I think, to wrap things up at work, in the sense that they said that you needed 3 months off. So I had to tell my management and the team that how we were going, all that kind of practical stuff.
Yeah,
and then I went for the robot assisted radical prostatectomy. That
yeah, I mean, they just removed your prostate, didn't they, Nick? I mean, that's simple as that.
And the seminal vesicles, they take everything out, and It's a very complex, skilled thing. And I did look him up online, my surgeon, and I was reassured about his the quality of his work and the work that he'd done. So personally, and what was published about his work, I was convinced it was the right way. And it says in my case study, some of the people I took counsel from, we used to talk about it. And then in the old urology wards, you know, if you had a radical prostatectomy, that you had quite a large abdominal wound, you know, generally you were in hospital for 2 weeks, and you went home in your pajamas and in a wheelchair with an indwelling catheter. And it was a big, because it's very difficult to surgically access your prostate. You know, when you look at the leaflet, you'll see that trying to get to it is very difficult, and hence how they had to kind of, there's probably histories of different ways surgeons have tried to get to it. In my day, it was from your abdomen and fishing through. Anyway, so my experience was 2 weeks, and was one from 2 weeks out in your pajamas in a wheelchair. I was in one night, and I walked out the hospital in 4 o'clock that afternoon, the afternoon afterwards. So I had one night. I didn't have huge amounts of pain. I had prescriptions. You have to take injections to reduce the risk of blood clots. You have to wear stockings. And I see a number of other guys found it quite hard to manage their catheters, because you need an indwelling one, for about 10 to 11 days. These kinds of things, for me, in this case, it worked to my advantage, giving the injections, managing the catheter, changing the bags, because you need a bag at night and the bag during the day. All that kind of stuff wasn't an issue. But I see that other people's stories, that was a significant problem, a challenge for them. But for me and Alison, in a way, it was quite good that my children were away at university. And I think that in a way made it easier, seeing I very kind of felt very conscious of seeing kind of a sick, shuffling bloke with a catheter would sort of impact on, but they were away. So Alison and I, we managed it. Her employers were sympathetic to her, so she took some time off in the early days to kind of, but I was, in common parlance, quite self-caring early on. And so I had an ambition. One of the stories that I found very powerful for me prior to surgery, and I was searching the internet, prostate and cycling, because there's a lot of discussion about whether if you ride a bike too much, it gives you prostate problems or not prostate problems. So I remember finding this American forum, and they were saying, I had my same operation, and they were on their bike within a certain amount of period. And my surgeon said, 3 months and you can get back on your bike. I'd actually bought in COVID, lots of people did, an exercise bike in the house. And so I thought that would be gentler on my perineum. So I'd had one of those bought for a different reason. So I remember getting a 3-month kind of, is it okay now to sit on the bike? And that was a real marker. But it was reading about other people's experience of getting back on their bikes, resuming their normal activities post-surgery was quite reassuring for me in the early stages, and it formed a kind of an important kind of part of my thinking. I'm over it. I'm getting better, and I'm entering into the post-diagnostic, post-surgery phase that I'm in now.
How are you now?
Well, it's I'm fine. It's good. You can't see it on the camera, but I'm touching wood. My current regime now is I have 3 6-monthly PSA tests, because without a prostate, you shouldn't have any of the.
You shouldn't have any PSA in your blood, really.
You shouldn't have any in your blood, and that was the first test. I remember the surgeon came round after the operation and said, "Oh, everything went all fine, you're all right, and we'll do a PSA test in a month," or whatever it was. I can't remember, because in theory you got no prostate, you don't have that particular antigen in your blood, and so that becomes the marker. Because if you have a more disseminated cancer, then that PSA around. So more or less, I have this very low level of PSA. It's kind of, in some senses, undetectable. And so each time I go in, and it is I can't remember if there are any other case studies, but it is a cyclical period of those follow-up checks. And each time you go and say, is it going to stay down, or did a cell get away?
Yeah.
Is it floating about somewhere, and is it going to start pumping out the antigen at some point in the future? And I suppose I don't know now whether that's what I've got to do forever now, 6 monthly, yearly. It's interesting, Jim, there's a guy up the road, he had the similar thing. He went private and he stopped having his regular PSA because it costs too much.
Yeah.
So I'm still cared for within the NHS, and they're offering me a 6 monthly check, and so far so good. And I'm back on my bike and that kind of stuff. So
I think the thing that I've taken so much out of talking to you about it, Nick, and I kind of mentioned it already in a way, is that just the massive improvement in these things. And even I was amazed when I was researching the booklet how much the diagnostics have improved. We understand the PSA so much better now. It's a very blunt instrument, because a lot of people with higher PSA won't have cancer, and some people, a smaller number of people with low PSA will have a cancer. So it's not.
That kept me going for months.
Yeah, it's not the greatest test in the world, but by adding these other tests in, obviously particularly the MRI and the free PSA, we're getting much better at diagnosing it more precisely. So there's not a danger of men having surgery that they don't need. And the surgery or whatever treatment you have when you do have it has improved so much, even in the last 10 years, even in the last 5 years. It's really clear to me from talking to the guys that I've spoken to, the sort of things that happen to, and there's a guy in the booklet who had his prostate removed, same operation as you, 20 years ago in 2002. The difference between what happened to him and what happened to you it's enormous. But he's nonetheless still going strong. So, prostate problems now, we can deal with them, and we need not. I think you'd agree, Nick. We need not to procrastinate. You could have gone several months earlier, I'm guessing.
I could have gone. I think I really could have done. I mean, I think even that last PSA that showed that increase, I could have gone in then. But I think I still wonder why I didn't act before. I'm glad that I did, because there's another guy, that I got it in time that the actual tumor was encapsulated
remain all in your prostate. Yeah,
all in the prostate, and had I left it any longer, if my daughter and my wife not pestered me, probably the reality is probably I would have been in denial still, and I should have known better. But again, just to amplify your point about one of the things that stopped me was my ignorance really about the developments in prostate cancer that you've highlighted there, Jim. And I think had I known that, I probably would have gone earlier.
Thanks very much, Nick. That's fantastic. Thanks for sharing that with everybody. We're just coming up to 12. I don't know if we can get the slides back up, can we? If we can, that would be great. If we can't, never mind. Just going to show you the so P for Prostate takes its place alongside a whole load of other manuals that the forum have got available. The web address there for the forum's website's at the bottom, menshealthforum.org.uk. So we've got several booklets on various topics, general men's health, and then specific aspects of it. And P for Prostate will join the group there. And there's loads of other information on the website, and you can sign up to support the forum's campaign and work. So yeah, it just remains for me to echo what Catherine's just said in the comments, which is to thank Nick very much for coming along and talking to us today and helping me to launch the manual. Thanks very much, Nick. Thanks very much, everybody.
And thank you, Jim. Thanks, everybody.
Thank you.